Inadequate staffing leaves patients at a higher risk of infection, skin breakdown, pneumonia, and even death. These negative patient outcomes decrease hospital reimbursements to greater and greater degrees. Today, institutions must find proven ways to deliver positive clinical outcomes in order to remain financially sound. Studies conducted in 2011 and 2012 show strong evidence of better patient outcomes when nurses can spend more time providing patient care. So the question then becomes, how do we know when we've staffed enough nurses to achieve safe patient care? How do we know when we've staffed enough nurses to achieve our desired clinical outcomes? Really, what are the best practices? Finally, how do we fund additional staffing to meet those needs? The five most common healthcare-associated infections cost $9.8 billion annually. All of these can be directly impacted by nursing care through increased monitoring and compliance with protocols. Surgical site infections are the most prevalent, followed by ventilator-associated pneumonia, central line-associated bloodstream infections, Clostridium difficile or C. diff infections, and catheter-associated urinary tract infections. A descriptive study published in 2012 about the individual effects of nurse staffing on infection rates showed that increasing a nurse's workload by just one patient was associated with increases of urinary tract infections and surgical site infections. In another study the previous year, surgical patients and medical patients showed significantly lower rates of pressure ulcers when nursing hours per patient day were increased. And when adding just one RN hour per patient day, the chance of pneumonia was decreased by 8.9% in one cross-sectional study on the effects of nurse staffing. The concern for and desire to achieve better clinical outcomes is an ongoing challenge of nursing. Centers for Medicare and Medicaid Services has added a number of quality indicators to improve healthcare performance. Their goal is for healthcare organizations to reduce or eliminate certain preventable adverse events. In 2014, up to 3% of a hospital's total Medicare reimbursement could be at stake. Our patients with the highest risk of infections require more interventions and closer monitoring. But each nursing task, whether it be an assessment, documentation, or intervention, all require time. And the cumulative effect of additional tasks for one patient ends up giving the nurse less time for the other patients. The right mix of nurses and patients are needed to reduce the probability of adverse events. Tracking nursing hours per patient day has been the consensus measurement of nursing care used for quality indicators. The Joint Commission recognizes various collection methods, from a midnight census to multiple census reports. Inconsistent data collection methods, however, can bias these measurements. For instance, estimating of average hours of short-stay patients has a potential bias as high as 7%. A 2011 study described the gold standard as a measurement of actual hours of inpatient and short-stay patients, but would require precise measurements of check-in and check-out times. In order to deliver world-class service, we need world-class innovation. This means using technology to help allocate resources more efficiently, focusing care based on the dynamic needs of each patient. So how do we know when we have enough nurses staffed? When we have timely completion of assessments, interventions, and documentation, when quality of care is no longer affected by adding additional staff, and when patients are satisfied with and because of their care. Patients and their families feel a greater level of satisfaction when a nurse is present. It's because the well-being of the patient depends on the nurse being there to assess and care for them. Staffing that provides more bedside hours can also, therefore, improve patient satisfaction scores. Finally, how do we fund the staffing of additional nurses? Well, in reality, we're already paying for those nurses not being there. With $9.8 billion annually for preventable healthcare associated infections, greater incidence of pressure ulcers, extended lengths of stay, and poor patient satisfaction scores. These all represent lost dollars that would be better spent if they were invested in direct patient care. States with mandated staffing ratios have shown significantly improved patient outcomes, but also increased nursing salaries. Other staffing models have improved staffing and clinical outcomes by adjusting nursing hours per patient day. The best practices in staffing should combine defined minimum staffing and an arbitrated process of nursing hours per actual patient days that are adjusted for patient acuity. By using best practices in staffing nurses, we can improve patient outcomes, and we can deliver the world-class care that our patients expect.